basically a widespread rash. They can be due to a number of things. Probably the two common are a drug reaction and an infectious process, a microorganism of some sort. I would say that the exanthems that you see in children are more from a microorganism, a viral infection or something like that. But you can obviously see there's more adults probably have drug reactions, but it's usually widespread. The three that were on the list for the NCCPA wanted us to know was erythema infectiosum, or Fifth's disease, hand, foot, and mouth, and measles. I cover a lot more in the pediatric section of the more pediatric rashes, so you'll get plenty more then. So let's start with erythema infectiosum, also called Fifth's disease, and you have to know parvovirus B19. That will be on a test at some point in your life, I promise you, a national exam. You tend to see this more in children. A lot of these viral type of rashes. Oh, bless you.
I'm sorry. I'm sorry. I'm talking to my arm.
No, bless you. You tend to see this kind of seasonally. This one you tend to see in late winter, early spring. So right about now is when you're going to start people walking in the doors with this rash. Kind of comes in waves. A lot of these things will just come in waves. School outbreaks, you'll notice that. And it's transmitted, like a lot of viruses, via respiratory. Okay, so most of the time, these kiddos don't experience any symptoms except for the rash. If they do, it's pretty non-specific viral type of, stuff a couple of days before the rash breaks out. There's a small percentage that will feel kind of achy, have arthralgias in children. Now in adults, it's kind of the very opposite. All right, so with Fifth's disease, this rash, how it very first starts is on the face, the cheeks. They get very red and edematous, a little bit swollen, and they look like they've been slapped on their cheeks, the slap cheek. And it's pretty marked. Then after a few days that fades, and then you start getting this kind of lacy patterned rash to the trunk and the extremities. All right. May or may not itch, usually not, but occasionally it can be kind of itchy. So reticulated is that term you use for that kind of lacy look. And this is self-limiting. It will go away on its own. It'll last about a week and a half, something like that. But you may notice that when a kiddo gets out of the bathtub, or they've been exercising or something like that, you may notice you'll see that lacy rash appear again. So that's the slap cheek on the screen left, and then screen right is that lacy reticulated rash on the trunk and extremities. So you might ask, if by the time they get into the clinic, they have more of this lacy patterned rash on the arms and the trunk, or just the arms, say, hey, several days ago, were your cheeks real red, and and then did you have any, even before that, did you have some, I don't know, runny nose or feeling kind of achy, viral type of symptoms? And that'll help you make your diagnosis. Now in adults, that's kind of just the opposite. They don't have as much of the skin rash, but they've got a lot more of the arthralgias. And my mom actually had this several years ago, and her arthralgias were pretty bad. I mean, it just kind of hit her all of a sudden, and she just hurt to raise her arms, and it was kind of a weird presentation. Well, she goes, and they ended up checking some blood work for the antibodies, and she had the antibodies against the parvovirus B19, so we had our diagnosis. Again, this is self-limited as well, but this one can stick around. Those arthralgias can stick around longer for months sometimes. I don't recall my mom having more constitutional systemic symptoms, you know, viral type symptoms, other than the arthralgias, but if a rash is present, they tend not to get the slapped cheek, but they may get more of that lacy appearance. But again, generally the adults are not going to have the rash. So your diagnosis is strictly by clinical, how they present. You know, if you need to, you can order the antibodies. The one complication is that occasionally, especially in people who have like sickle cell disease, they can sometimes get this transient aplastic crisis where their body quits making red blood cells. And they're going to present with extreme fatigue, they're going to be very pale, and anemia, obviously. Now, the one thing that's really important to know and remember is Fifth's disease is not good with a woman that might be pregnant. Because it can cause spontaneous abortion in the early part of the pregnancy, and in the latter part of the pregnancy, it can cause this hydrops fetalis, which is where in utero they develop fluid in certain compartments, such as their lungs or their brains, things like that. So I would be familiar with that it can cause spontaneous abortion and the hydrops fetalis. So if you have a pregnant woman that has been exposed, I would probably test for the antibody to see the IgG and IgM, just to see if she has it, so they can, you need to send her to an OBGYN so that they can monitor her closely. They'll do frequent ultrasounds to monitor the baby. Okay, so there's really no treatment for this. It's gonna take care of itself. It's gonna go away on its own. You just kind of treat the symptoms. All right. So hand, foot, and mouth disease. Again, children less than 10 are the most commonly affected. Rarely do adults get this. Summer and fall are the seasons that you tend to see this. This is highly contagious, and the Coxsackie and the enterovirus, but I want you to especially remember the Coxsackie virus. All right, so once a person is exposed, then several days later, they're going to start developing some lesions in the mouth. This always starts in the mouth. And they don't get blisters really in the mouth, but they get these ulcerations in the mouth. They may be just a few in number, tongue, buccal mucosa, hard palate, and less frequently do you get it down in the back of the throat. After that, a big chunk of the people, about 2/3 of the people, will then start developing little oval-shaped blisters, mainly to the feet and hands, but it can be other places. So it's going to start, before it develops a blister, it's going to start as just an erythematous macule, papule, and then it will develop a blister or vesicle with this little red halo, and then it will form a crust or an erosion in the mouth. And there are some pictures of that. Again, the diagnosis is made clinically, no blood work that you need to get. The only rare complications is this aseptic meningitis. Again, this is self-limiting. It's just going to go away on its own after about a week, week and a half. And you just mainly need to treat supportively because those erosions in the mouth are painful. Your little kiddos don't want to eat or drink, and you really need to push fluids at least to keep them hydrated. Dehydration is probably your main concern there. Measles. Measles is, thank goodness, we don't see it much here in the United States because we've done such a great job of immunizing our kiddos for it. However, we are starting to see a reoccurrence of some cases of measles. But it is one of the most, or a very deadly worldwide infection that could be preventable with vaccinations. Winter and spring are the seasons you're going to see this. So again, right now. And again, U.S. immunization has decreased it by 99%, so that's fantastic. Again, respiratory droplets, most viruses are spread that way, or a lot of them. So this one you need to remember that a person can be contagious up until about 5 days into the rash. For other people that they could be exposed to. So this is going to start with, before any rash starts, they're going to start with some constitutional symptoms, and I want you to remember the 3 C's: conjunctivitis, coryza or runny nose, and cough. All right, so conjunctivitis, they're going to have kind of, red, irritated looking eyes, maybe watering a lot. They're going to have runny nose and a cough. And then and fever, excuse me. And that fever can be pretty high, up to 104.9. So they're going to feel pretty sick. And then as the fever's coming down, that's when the rash is going to start. All right, and this is a non-paretic rash, so it's not itchy. It starts at the head, especially at the hairline and behind the ears, and then it spreads to include the rest of the face and downward. All right. And this is pretty widespread, and will then resolve in 4 to 6 days later. Now, you're going to find so many of these viral exanthems look just alike. I mean, you're not going to be able to tell one from the next one. It's going to be more that history. All right, how high was your fever? Did you have runny nose, watery red eyes, cough? How long before your rash started? Things like that. How long did the fever last? So that could look like a drug rash, you just have to, that's where history is so important. Measles also has an exanthem, which is a rash or changes on a mucosal membrane, on the mucosa. Here, it's in the mouth. On the buccal mucosa, across from the premolars, you may see these little bluish white spots called Koplik spots. You have to know that for potential exam questions. I've seen this on exam questions, and I know you will too. So star that. So the entire thing, illness lasts around 10 days. Maybe the rash may take a little bit longer to clear up. May be associated with some other, may get a secondary otitis media, things like that. And there's a picture of your copal spots. Know what they are, know what they're associated with, for sure. Again, you can get you can check for the antibodies if you are suspicious that this is measles, and I probably would do that. There's other ways that virus also is not only do you see antibodies in the blood, but you will also get virus in the nasal, so you can do a nasal swab or nasopharyngeal swab, and also in the urine. So again, you might try to get more than just one. If you are suspicious for measles and you want to get confirmation, you might do more than one testing. Now the thing about measles that is so worrisome, you just hear that and you're like, well, there's nothing wrong with a little fever or high fever, runny nose, cough, and a rash. What's problematic are the potential complications. And those are otitis media, pneumonia. Pneumonia is the key one right there. Bronchitis and secondary diarrhea. But it's the complication of pneumonia that can be life-threatening, is the most life-threatening problem. The most common fatal complication. You can also get an encephalitis. 1 in 1,000 measles cases will get an encephalitis, and this can lead to permanent brain damage. So those two things, may not kill you, but it can stick around, affect you for the rest of your life. There's also a very rare potential side effect, is subacute sclerosing panencephalitis. You're not going to see immediately, but like 7 to 10 years after you've had the infection. It's more of a degenerative, central nervous system degenerative disorder. So that's why we want, all these things are why we want to vaccinate, not because of the rash and the fever. Treatment's primarily supportive. Again, it's a virus, not much you can do. If a person happens to have a secondary bacterial infection, by all means, you can treat that with an antibiotic. You have to educate your patients for other family members, other people that they may expose, to stay away from people until 4 days after the rash has started, 4 to 5 days after the rash has started. I didn't realize this, but severe cases of measles, especially when they're needing to be hospitalized and such, lowers your vitamin A level, and so they will supplement with vitamin A. I did not know that. And sometimes in if you've been exposed and you're at high risk, a very young person, less than 1 year of age, a pregnant woman, things like that, they may give you immunoglobulin, just to hope that you don't actually come down with the symptoms. Any questions? Pretty self-explanatory.